Hello everyone. So today we will be talking about splints and tractions. So splints and traction, they are a very important part of day-to-day orthopedic practice. So first let's start with splints. So splint is basically any rigid device which is used to immobilize the injured part of the body. So the main purpose of using splint is to prevent further trauma to the affected part and to reduce pain. So any rigid material like this wooden plank can be used as a splint in emergency conditions. So splint may also be used in post-operative period for rest and support. We can use knee brace in cases of ACL injury after the surgery. It can also be used as a definitive treatment to treat fractures or deformity in form of POP cast or slab. So this is a plaster of Paris cast we can see in these pictures. Now let's talk about the indications of splint. So it can be used for transportation purpose, as we already saw that any rigid device like that wooden plank can be used for transportation purpose. This Cramer wire splint, it can also be used for transportation purpose. It can also be used for traction by attaching the splint to the traction system. It can be used for deformity correction, like Dennis Brown splint can be used in CTEV or clubfoot. It can be used to prevent the deformity, like dynamic cock-up splint can be used in radial nerve palsy and brachial plexus injury. So it can also be used to provide rest to an acutely inflamed joint, like knee brace can be used in tuberculosis of knee, and ankle brace can be used in cases of ankle sprain, and it can also be used in the post-operative period as immobilizers. So first let's start with this Cramer's wire splint. So it can be used for temporary splintage of fracture during transportation. So in this figure we can see that it has two big thick parallel wires and multiple small wires in between. So it can be easily bent to different shapes in order to support the fractured limb. So it can be used in upper limb as well as lower limb fractures. In this figure we can see this has been bent in a certain way to support this fracture. Another one of historical importance is the Thomas splint. So it was initially devised by H.O. Thomas for immobilization in cases of tuberculosis of knee, but nowadays it is commonly used for immobilization of hip and thigh fractures. So we can see that it has an outer bar, inner bar, and there is a certain bulge in the outer bar. So this bulge accommodates the greater trochanter, and there's this ring, and this ring forms 120-degree angle with the inner bar. So in this picture we can see that the ring has been engaged in the groin, and the bulge, it accommodates the greater trochanter. So this ring, it provides the counter traction. So we can see that a traction system has been connected to this Thomas splint. Another one is the Bohler-Braun splint. So it is generally used for tibial and femoral fractures. It has been attached to a sliding traction. So we have got three pulleys here. So the pulley A is for giving traction to the calcaneum or tibia. Pulley B gives femoral traction, and pulley C is used to change the direction of the traction. So this is a Bohler-Braun splint which is attached to a traction, sliding traction. So there are various types of splints in different forms. So this is the knee brace, long knee brace. This is the Dennis Brown splint or CTEV splint, which is used in cases of clubfoot. This is lumbar corset. It can be used in cases of backache. This is Volkmann splint. So it can be used in cases of Volkmann's ischemic contracture. This is tennis elbow brace. It is used for tennis elbow. And this is foot drop splint, which can be used for common peroneal nerve injury. Now let's talk about taking care of the patient in a splint. So splint must be applied properly, and it should be adequately padded at the bony prominences and the fracture site with the help of cast padding, cotton padding. So the bandage of the splint, the creep bandage that we apply, it should not be too tight or too loose, and patient must be encouraged to exercise the muscles actively on their own, and the joints should also be moved and exercised inside the splint as much as it is permitted. We should detect any compression of the nerves or vessels due to tight bandage or inadequate padding early, and it should be managed early. We should check for the splints regularly, and we should take regular x-rays in order to ensure the correct position of the fracture. We should always be vigilant about compartment syndrome, about the development of compartment syndrome. So diagnosis of compartment syndrome can be made on the clinical suspicion of a tense swelling and severe pain on passive stretching of the limb. So this is a very important point to notice. We should also encourage the active movement of the toes and fingers distal to the splint in order to reduce the swelling, as well as to reduce the muscle wasting due to inactivity. Now let's talk about tractions. So tractions are basically the devices which counters the forces that does not allow the reduction or alignment to happen. So traction is applied to the limb distal to the fracture. So it exerts a continuous pull in the longitudinal axis of the bone with a counter force in the opposite direction. So we should always note that traction must always be opposed by a counter traction system. Otherwise, it just pulls the patient off the bed, which we don't want, obviously. So traction also requires constant care and vigilance, because it is the patients with traction have to go for prolonged bed rest. So the patients, they are associated with the hazards of the prolonged bed rest, like decubitus ulcer and thromboembolism and UTI and pneumonia and etc, etc. So yeah, in modern orthopedics, traction has a very limited role. We don't see traction being used as often as in the past. So it is merely used as a temporary measure to bridge the gap from the fracture to the definite treatment. Now let's talk about the indications of traction. Traction is used to immobilize a painful inflamed joint or fractures. It can also be used to achieve a normal anatomical orientation in cases of fractures and dislocation when surgery is delayed or not possible due to different medical reasons. It can also be used to reduce the muscle spasms and deformities, and also to relieve the pain, because if the patient is immobilized, then the pain also reduces. It can also be used to correct the soft tissue contractures, torticollis of the sternocleidomastoid, by stretching them out. So let's talk about the types of traction. So there are three main types of traction: fixed traction, sliding traction, and combined traction. So in fixed traction, the counter traction is provided by the traction system itself by attaching over a body part. So in this Thomas splint, the traction system, it attaches to this greater trochanter in the groin region, and this greater trochanter, it gives the counter traction. Another one is sliding traction. So in sliding traction, the weight of the body, the entire body, it acts as the counter traction. So this sliding traction it is made effective by elevating the foot end of the bed. So in this figure, we can see that the foot end of the bed has been elevated, and this traction has been counter traction is given by the entire body weight. So the traction system is applied to the Bohler-Braun splint, which has different pulley systems, as we can see. So yeah, another one is combined traction. So combined traction basically combines the fixed as well as sliding traction principles. Now let's talk about different methods of applying traction. So there are three main methods. One is traction by gravity, another is skin traction, and another is skeletal traction. So in traction by gravity, this is only applicable for upper limb injuries. So in this figure, in this picture, we can see that this wrist sling, it supports the forearm, and it gives continuous traction by gravity to the humerus. Another one is skin traction. So skin traction is a non-invasive method, but more than, if we need to attach a weight of more than 4.4 to 5 kgs, then skin traction will not sustain it. So we need to go for skeletal traction in those cases. So skin traction basically involves applying splints and bandages and adhesive tapes to the skin directly overlying the fracture and attaching certain weight to it. So there are certain complications of skin traction as well. So the patient may develop skin allergies from the adhesive material. There may be skin excoriations and abrasions to the skin due to the bandage. The patient may develop pressure sores due to prolonged bed rest, and there may be compression of the superficial nerves due to inadequate padding beneath the bandage. So yeah, this is about skin traction. Now let's talk about skeletal traction. So skeletal traction is an invasive procedure, and it involves placing a pin, wire or a screw in the fractured bone and attaching weights in order to pull the bone in the correct position. So it is basically applied when the patient cannot be operated as soon as the fracture occurs, in order to buy some time, because in that time there are various deforming forces like the soft tissue surrounding the bone, the fractured site, which may deform the fractures in different direction. So in order to prevent those deforming forces to act, we apply the skeletal tractions in order to pull the bone in the correct position. So skeletal traction, it may be applied over general anesthesia or local anesthesia or spinal anesthesia. Generally it's done under local anesthesia, but any type of anesthesia can be used. And it is usually used only when greater force is needed to apply to the affected area. But if it is only required for immobilization purpose, then skin traction is okay for that purpose. So the force is directly added to the bone, so more weight can be added with less risk of damaging the surrounding soft tissues. Now let's talk about different sites for skeletal traction. So the most common site to give skeletal traction is the proximal tibia, as we can see in this picture, in the proximal tibia. So we should always insert the pin from lateral to medial, because laterally there is fibula, and in the neck of the fibula the common peroneal nerve passes. It rounds around the fibular neck. So in order to prevent the injury to the common peroneal nerve, we always go from lateral to medial, because it is a blind procedure. Other important sites are the olecranon, the distal femur, the distal tibia, the calcaneum, the greater trochanter. So in this picture we can see the skeletal traction being given at the calcaneum. Now let's talk about different implants used to apply skeletal traction. First, let's start with the Steinmann's pin. So Steinmann's pin is basically a pin which does not have any thread in the middle, and it has a trocar tip which is used for insertion. Denham's pin is a pin which has a thread in the middle. So Steinmann pin cannot be used in cases of osteoporotic bone or in cases of cancellous bone, because they have bigger pores in between, inside it, unlike the cortical bone, which is compact and it does not require any thread in between for the grip, whereas in the cancellous bone, like this, in the calcaneum is also a type of cancellous bone, we need to use Denham's pin, because if we use the Steinmann pin, then it may lose the grip and it may slip out. So Denham's pin has a thread in between, so it provides a firm grip to the cancellous bone and to the osteoporotic bone. Another implant is Bohler's stirrup. So we apply the pin here and we hang the weight over here. Now let's talk about the complications of skeletal traction. So there may be adverse reaction to anesthesia, whichever it is used. There may be bleeding from the pin track site. There may be infection of the pin track site. There may be damage to the surrounding tissues. There may be neurovascular injury due to the pin insertion, as it is a blind procedure. There may be hazards of prolonged bed rest, as we already talked about it. Now let's talk about which traction to apply when. So skin traction is preferred whenever possible because it is a far less complication. It has far less complications and it is a non-invasive procedure. So if traction is required for immobilization purpose and surgery is planned soon, then we use skin traction. So for skin traction, about 4 to 5% of a patient body weight is required. But if more than 5 kg weight is required, then skin traction cannot be used. So for alignment purposes, for reduction purposes, minimum weight required is about 10% of the patient's body weight. So for these purposes, skeletal traction is always ideal. How do we take care of a patient in traction? So traction should be as comfortable as possible for the patient, as the patient needs to be in traction for a long time. So the patient's comfort should be the priority. Proper functioning of the traction unit must be ensured, and the traction weights, it should not touch the ground, otherwise it does not serve its purpose. The terminal part of the limb in traction should be warm, of normal color and with intact sensations, because there is something called traction palsy of the nerve, which may result in tingling and numbness sensations of the limb. Any swelling must be checked because the swelling may result from a tight bandage or due to slipped skin tractions. If there is severe pain on gentle tapping at the site of pin insertion, then that may signify pin tract infection. Proper position of the fracture must be ensured by taking serial x-rays in between, and physiotherapy must be continued even while in traction in order to minimize muscle wasting. And we should always be vigilant about the complications of prolonged bed rest like bed sores, thromboembolism, constipation, UTI, pneumonia, etc. So these are my references, and thank you for watching this video. If you have any questions, then you can drop down in the comments, and I hope you learned something from this video, and I will see you in the next one. Thank you.